on because they need to put the slide changer and the other things. That will not delay us. We're going to start straight away. Thanks very much for all of you for coming. It is quite extraordinary, quite unbelievable. And I also have to say special thanks to Bill. Bill, it is a real privilege to have you here with us. It is about asthma and allergies, and I'm going to give you my personal view, the road over the last 25 to 30 years, the line of thinking and the research that we've done at various places. And really, I think the moment when I realized that asthma is a problem is probably around this time. That's my dad and mum and myself in front of University Children's Hospital in Sarajevo, where he was a professor of pediatrics. And every year, he would have to spend 2 months working in a sanatorium for sick children on the coast, close to Dubrovnik. The reason was that all children with severe respiratory diseases and asthma would be sent from a polluted city out on a coast to make them feel better. And as a boy, I thought, you know, asthma is real rubbish. You have to go away from your family. And, you know, it clearly has something to do with the environment, because when you change it, it appears to get better. I mean, don't get me wrong. At that early age, I really didn't want to be a doctor. I was a very shy baby right from the start. So I tried all sorts of various things that would interest me. I did my very best, but I don't think I was quite good enough. You know, this unlikely character here, this guy, he actually became a bona fide rock and roll star. My bass playing was so rubbish that I couldn't even make it into a punk band. Nonetheless, here I am, and I think I made the right call. I did have another opportunity to play. It was one of the ATS meetings in, I think, around New Orleans, isn't it, Ashley? And that's about the only instrument I can play, a single string. So I failed in all of these interesting things. What else can you do? You become a doctor. And 1987 was really important year. First of all, in 1987, this heavenly creature entered my life. And after that, probably nothing would ever be the same. At the same time, I started my specialist training in pediatrics. And after 6 months doing oncology, I decided I was going to be allergist. And it was great. Over the next 2 or 3 years, several publications came out that really shaped the way of thinking and what I was going to do in the future. Those were 2 crucially important papers that made me think. The first one, the work by Nicola Wilson, often overlooked, but tremendously important paper in which Nicola, for the first time, raised tremendously important question. Can we really call all the childhood wheezing asthma? She also, in 1988, proposed that there are different types of responsiveness. There is viral hyperresponsiveness, atopic hyperresponsiveness, and bronchial hyperresponsiveness. And then the combination of these different ones will give you fundamentally different diseases. Wheezy bronchitis, asthma, or allergic asthma. It was a big controversy in these years. But it made clinical sense. The other paper that really captured my imagination was the one by Tom Platts-Mills from Charlottesville in Virginia, the report of a first international conference on the role of house dust mites in asthma, outlining this idea that it is house dust mite allergen exposure and indoor environmental exposures that may be driving these important diseases. So thinking about it, I kind of thought, well, actually it is very clear what I need to do. I need to go first to England to learn about this, go to Hammersmith, and then go to US. So I got 2 fellowships, a year, British Council, to come to the UK, and then another 3-year fellowship to go to the US. So, you know, a 5-year plan was clearly there. But as all of you know, the best laid plan of mice and men you end up in a very different place. First thing that has changed is this young gentleman entered our life, so all of my plans were kind of moved by about 6 to 9 months. So I had to delay my trip to the UK. I stayed for another 6 months in this wonderful city, and then in January 1992, I was finally due to go to England. The baby was about 6 weeks old, perfect timing to leave the house. A lot of things have changed. I was supposed to work with John Warner. John moved to Southampton. I didn't really fancy Southampton. Seb moved out of Southampton. We all know why. So out of the wonderful city of Sarajevo, I ended up in Manchester. In Duchess of York Children's Hospital and Wythenshawe Hospital with a great pediatrician called Tony Robinson. I thought Manchester must be good. You know, the birthplace of Smiths and Joy Division has got to have something. Oh my God, did it rain. For the first 6 weeks, it never, ever stopped raining. The plan was always that Zdenka and Daria would join me. They did join me, but under rather different conditions than we thought. They did leave the city, but it was in a military transport plane, in its bowels, the last plane to leave airport in 4 years. They left the city at mercy of lunatics around the city in the hills who did this to pediatric hospital, this to National Library, and that to its people and citizens. So as if this wasn't enough for us to deal with, the 3 of us suddenly became 4 of us with the arrival of this absolutely lovely young lady. And I have to say, seeing 2 of them grow was the greatest joy of my life. It was absolutely fantastic. Actually, having them was just a joy from another point of view. That was the first PPI that we had. Gina Carey looked really carefully after them because every single thing that we did in our birth cohort studies, they were the first one to try. It was very important for me because if I was happy for my children to undergo different procedures, I could ask parents of other children to do it. We also got really great feedback. I learned from Daria that dry, cold air challenge is not something one should do to humans. And this, after all, is kind of our biggest achievement. See them grow into people they are has been absolutely fantastic. But back to Manchester to 1992, to Duchess of York Children's Hospital. And Tony Robinson really proved a great man. Called me and said, listen, there's really nothing I can do for you. You're wasting your time with me. What you need to do, you need to go and see one man. And there's only one man in Manchester you should see. And he isn't a pediatrician, but he's a great guy. So you should go and see him and talk to him. So I did, with an open eyes, went to see Ashley Woodcock. And it was love at first sight, wasn't it, Ashley? Despite the gross mustache that he has there. He was very popular in San Francisco. It was absolutely extraordinary. I told Ashley, listen, you know, I want to do an MD with you, give me a job. And he said, when do you want to start? Quite extraordinary. It was a start of fantastic working relationship, but much more important than that, it was the start of unbelievable friendship. A man I can call my best friend, and whom I managed to persuade to get rid of mustache as well. And we were not going to mess around. We were not going to joke about this. We were to address big questions. We were going to address big issues. And the big issues were there. We were facing this incredible epidemics of asthma and allergic diseases, diseases that were increasing at an unprecedented rate, 5-6-fold increase in prevalence. The question is, what on earth is going on here? So we decided to ask big questions. And our big questions was, what causes asthma and allergies? Why on earth are they on the increase? Can we prevent them? And can we find the cure? It is interesting. 25 years on, these are still the same big questions. Are we any closer to finding an answer to these big questions that we posed 25 years ago? Well, I sincerely hope that we are. And right at the start, we thought, if asthma is increasing, if allergies are increasing, we shouldn't just be sitting in the UK where that has happened. We should go out and find places where that increase is happening right now and try to probe it. And the studies that actually started in Ghana with this incredible gentleman called Emmanuel Adeyobo, we did a series of studies trying to ascertain what is the risk factor for asthma, an increase in asthma in this particular environment. And what was clear is that contrary to the dogma at the time that it was urban living, it wasn't urban living per se that increased the risk of asthma. It was affluence and hygiene. Asthma in Ghana was disease of affluence. And in the further studies, we have shown that over a very short period of time, over a decade, the prevalence of both asthma and allergy has doubled, which is quite extraordinary. In another study that we were very fortuitous to be part with, which was led by John Britton and Sarah Scrivener in Ethiopia, looking at what makes kids asthmatic in town of Jimma, proved another clues which were really interesting. The risk of wheezing among children was considerably lower. It went down with the increasing number of various hookworm eggs. So it was parasites. And not only that, it was the amount of parasitic infection that was inversely associated with asthma. More parasites, less asthma. At the same time, in the same children, the amount of dust mite allergen in their homes increased, and with that, risk of asthma increased as well. And this kind of start to form the hypothesis of what may be going on. Informed, amongst other, the hygiene hypothesis most of you will have heard about. The idea that in affluent countries we have become a little bit too clean for our own good. You need exposure to bugs. You need exposure to microbes in early life to educate your immune system. And if that is missing, then there is a delay in maturation and the onset of diseases, immune-mediated diseases like allergies, asthma, but also autoimmune diseases like diabetes. At the same time, our ever tighter homes facilitated much higher exposures to allergens, which could have contributed to increase of these diseases as well. So we thought, okay, we'll get the answer to this. What we're going to do is we're going to start a birth cohort. Probably the best decision we've ever made. That was the start of Manchester Asthma and Allergy study, and a lot of people who have worked with it and on it right from the start are here in this room. Starting in '94 and going, I hope, going for a long, long, long time to come. In addition to that, we wanted to prevent asthma and allergies, and we were going to approach it from 3 different points. At that time, we all became aware that asthma was inflammatory disease. So the idea is if we can switch off that inflammation, if we can kick in very early with anti-inflammatory drugs, that will stop the process and everything will be hunky-dory. The other approach was to give good bugs, to give probiotics, because if we restore the diversity, somehow we hoped that would change the outcomes. And the final third approach was let's go and try to remove allergens. Let's try to get rid of them and see whether this is going to get rid of asthma. And it was environment that we were very interested in. So we thought we need to measure environment meticulously, which is easier said than done. And going back to what Lord Kelvin said, you know, if you can measure things, if you can express them in numbers, you know something about them. If you can't express things in numbers, then your knowledge is of a meager and unsatisfactory kind. We realize that if we are to look at the role of environment, we have to measure it precisely and meticulously. And Ashley had a great idea. Okay, you have your Fogarty, but forget about that. Why don't you go to Charlottesville to see Tom Platt's Mills? They were developing novel methodologies for measuring personal and environmental exposure. Go and learn. So I did. Went to Charlottesville, met Tom, and that was another start of another wonderful friendship that lasts up until these days. And it was great having him here a few weeks ago, the first FRS in allergy since Osler. At the end of my 3 months in Charlottesville, Tom suggested that after everybody goes, I should go look into the freezers and take some samples of monoclonal antibodies, which I duly obliged. came back with sufficient samples to last about 8 years. Now, Tom, I'm sure, was not really angry because that's exactly what he did with Ishizaka when he left his laboratory, and I'm sure that that was exactly his intention. So he embarked on a work to try to understand what is allergen exposure, how does it occur, and what is the relevance of it to allergic disease. And we were the first one to demonstrate very clearly that in the UK and the other areas of the world with high proportion of pet ownership, exposure to pet allergens, cats and dogs, is ubiquitous. Every home in England, irrespective of whether it has ever had cat allergen, wherever you went, we went into pubs, hotels, schools, cinemas, airplanes. Allergens were everywhere. We could detect airborne cat and dog allergen in plenty of homes that have never ever housed a cat, and have shown that there are marked differences in the type of particles that carry house dust mite allergen, which was rather large, and cat and dog, small particles, probably accounting for completely different clinical presentation of a disease, where pet allergic individuals always know that they're allergic because they develop symptoms within minutes of entering a home and inhaling these particles that are very small. Dust mite allergic people very rarely are aware of their allergies. We then went on and asked another question. Amongst asthmatics, those who are sensitized, are they at risk of having more severe disease when their exposure in the home is higher? And indeed, this is work by Leslie Lowe showing very clearly that as early as age 3 years, children who are allergic and exposed have diminished lung function. Your bog standard primary care asthmatics have progressively worse airway reactivity with increasing level of dust mite allergen in their bed. And even in brittle asthmatics, what characterizes this severe disease is a combination of high allergen exposure and specific sensitization. At the same time when we were doing these studies, Seb Johnston was doing his seminal work demonstrating that it was viruses that were the main cause of severe exacerbations. And we were quite interested to see severe asthma attacks. Does allergen exposure have to do anything with this? And in 2 studies, and I'm still very proud of both of these, in these 2 studies we have shown very clearly that it isn't allergy per se, it isn't exposure per se, it isn't even virus per se. It's a combination of allergen sensitization, high exposure to allergen, and respiratory virus infection, predominantly rhinovirus infection, that increases the risk of hospital admission by 7-fold in adults and by staggering 20-fold in kids. This was the first study that we did with Seb Johnston. Again, start of a wonderful collaboration and even better friendship. I think it looks pretty cool for a grandfather. Congratulations, Seb. By that time, we thought we need to do something about this. If allergen exposure is driving disease, then surely by reducing exposure, we will make disease better. And this is a seminal study looking at the effectiveness of house dust mite impermeable mattress, pillow, and quilt covers in adults with asthma that Ashley has led, in which we have shown, unfortunately, absolutely no effect. And people really proclaimed that this was a proper sort of nail in a coffin of allergen avoidance as a strategy. Andy has always harassed us to do a study looking at the effect of allergen avoidance, but not on standard asthma outcomes, but on asthma exacerbation, asthma attacks, because the work we did with Seb has demonstrated that it's asthma attack that increase. And rather than sitting and waiting and sort of saying this was the end of it, in a very recent study led by Angela Simpson and Claire Murray, we have shown very clearly that amongst children, the risk of acute asthma exacerbation leading to hospital presentation is dramatically reduced by the use of mite impermeable encasing. Actually, the size of the effect, the halving of a risk, is as big as the size of the effect of important biologics that we have in asthma. The only difference is this intervention is about 100-fold cheaper. And quite frankly, I would rather have my bed covered than having injections every few weeks. At the same time, our primary prevention studies were coming up with all the wrong results. We had this first idea that asthma is inflammation. We turn it off, and by turning it off, asthma is going to disappear. But in this similar study of the use of inhaled corticosteroids very early in the disease process, it was absolutely clear that inhaled corticosteroids were just a symptomatic drug. As long as children were receiving them, there was an effect. The moment it was stopped, all the effect disappeared, and this really aggressive early treatment had absolutely no effect on the development of asthma. Not only that, there was a signal there that children who received this treatment very early in the first year of life actually had worse outcomes. And it really changed my practice, and it changed a lot of guidelines, and it was quite an important but negative study. What about giving good bugs? We were very, very, very lucky to have Claudia Go joining our team. Absolute joy, actually, that she is now clinical lead here, and what a clinical lead she is. So Claudia spent 3 years doing this incredibly difficult study of giving children, giving babies, young infants within the first 6 months of life with severe eczema, 2 different types of probiotics. Unfortunately, all of the outcomes being negative, no effect on eczema, and more importantly, absolutely no effect on the famed atopic march. Nothing was changing. It didn't stop it at all. And our stringent allergen avoidance, that John Warner used to call the mother of all intervention studies, where we completely obliterated house dust mite allergen exposure, reduced it 90%. Well, yes, there was a bit of effect on wheeze, but in completely counterintuitive findings, rather than reducing allergen sensitization, the sensitization was actually doubled. We very deliberately never published in the last 10 years because we couldn't quite understand what was going on. I think now we're beginning to understand what the problem is. At the same time, epidemiology was not making it any easier for us. In, beginning of 1990s, it was really simple. It was linear model. There's an environmental exposure, which leads to the development of sensitization, which leads to asthma. You remove environmental exposure, everything will be fine. Genetics, there's a genetic variant, it leads to asthma. You find it, everything will be fine. Now, what epidemiology was saying is, it's anything but fine. A lot of completely contradictory findings. Let me just give you a few about cat ownership. Beautiful studies showing that having cat is about the best thing that can happen to you. Equally good studies showing, well, having cat or not having cat doesn't really matter. And then third group of studies showing, well, actually having cat is seriously bad. And then similar studies with breastfeeding that really sort of created a lot of controversy, being protective or increasing risk on not matter at all. So all of this environmental science has really failed to help us to predict the disease, to change treatment choices, to understand natural history, to help with primary prevention. And then this happened. Of those of you who don't remember, this is June 2000, and it's President Clinton with Francis Collins and Craig Venter. It is decoding the book of life. And those of you who watch CNN or BBC then will remember the premise. The optimists in the press thought that we were finally up for eternal life. The pessimist said, well, at least we will have a cure for all of the diseases. And yet, 16 years of post-genomic era, what has it changed in asthma? Well, precious little. Precious little has changed. Apparently, asthma genetics has failed to deliver, both in terms of identifying individuals at risk, changing treatment options, predicting natural history. There's a lot of genes, a lot of genetic variants, and precious little consistency. And the articles began to appear in Nature saying, these asthma researchers, they don't have a clue what they're doing. They're doing wrong type of studies, too smaller studies, and generally speaking, they should go home. Now, the other way you can ask the question is, all of these contradictory findings, are they actually telling us something fundamentally important about the nature of this disease? And I'm going to tell you two short stories that can explain at least some of these discrepancies. First, story of endotoxin, LPS, and CD14. Why these two? Endotoxin is part of outer wall of gram-negative bacteria. It can actually be used as a marker of exposure to bugs. Now, if hygiene hypothesis is correct, then higher the exposure to bugs, the lower the risk of asthma and allergies. CD14 is part of a receptor for endotoxin on a cell, together with toll-like receptor 4 and MD2. And signaling through this pathway leads, amongst other things, to production of interleukin-12, and in mouse model, theoretically, less allergy. So what was the epidemiology? Oh, the epidemiology is remarkably, remarkably interesting. Because when you look at endotoxin, these are fantastic studies from Germany showing what you would expect. The higher the exposure to endotoxin, the less likely you are to be allergic. So far, so good. But then you go from Germany to Estonia, and in Estonia, endotoxin doesn't matter anymore. And then in a study that we did in south of Europe, in Cyprus, where we had one of our research fellows, it was exactly the opposite. Endotoxin exposure actually increased the risk. So you have the story of asthma, don't you? Same exposure. In some studies, great for you. In another studies, it's really bad for you. In third group of studies, it doesn't matter. What about CD14? This was really, really interesting story because towards the mid-90s, one of our later close friends and collaborators, Fernando Martinez, described a functional variant in a promoter region of CD14 gene. What does it mean? That means that children with different variants had different levels of gene product, of soluble CD14. So children who were T allele homozygotes had more soluble CD14 than those who were C allele homozygotes. Now, Fernando then said and argued that if this is true, then the signaling through endotoxin pathway will be much higher amongst children who have T allele, and that by virtue of that, they will have less allergies. He genotyped all the kids in his birth cohort study and has shown exactly that. It was fantastic. It was game, set, and match. Functional polymorphism, biological underpinning, genetic association. I mean, what more can you ask? Well, a tiny little bit. Replication. And Mikhail Kadesh, who worked on this study as a research fellow in Tucson, went back home to Germany, tried to replicate, and failed dismally. In Germany, gene did absolutely nothing. And then the plot really thickened. Because one of the world's foremost geneticists, Carol Ober, decided to do a replication study in a population of Hutterites, one of the founder populations living communal agrarian lifestyle, all living on farms. And lo and behold, Carol replicated the finding. There was association, but it was a replication with a twist. And the twist was that the same genetic variant that was protective in Tucson, Arizona, increased the risk amongst Hutterites in South Dakota. That's what I call replication with a twist. And interestingly, imagine in asthma literature, if you find exactly the opposite findings, you still call it replication. That always amazed me. Always amazed me. Anyway, when you look at the worldwide studies, third of the studies show that one allele is protective, third of the studies show that the same allele is risk, third of the studies show that this gene doesn't matter. And you look at this body of evidence, what would you say? It's kind of nonsense, isn't it? Would you feed children with endotoxin based on this? No. So it may be that all of these studies are wrong, or it may be that they are telling us something different. Meantime, in Manchester, Ashley and I have learned how to measure environmental exposures. We had very precise measure of allergen and endotoxin exposures. We were interested to see whether in our study endotoxin is good. And indeed it was. There was a decrease in risk of having allergic sensitization with increasing level of endotoxin. In our population, just like in Germany, perhaps influenced by Claudia, the gene CD14 didn't matter at all. We looked at this and thought, hang on. CD14 is part of a receptor for endotoxin. Wouldn't it be possible that children with different genetic variants have different signaling, and as a consequence of this, the effect of endotoxin on development of their allergy may differ? So we reanalyzed the data, but now looking at subgroups of population. And then it became really interesting, because 25% of kids who were T allele homozygotes, endotoxin was not important at all. 50% heterozygotes, endotoxin still didn't matter. But in last 25% of kids, quarter of a population, exposure to endotoxin was tremendously important. If kids were C allele homozygotes, when exposed to very high level of endotoxin, they were almost guaranteed not to be sensitized. When not exposed to endotoxin, they were almost guaranteed to be allergic. And we were very excited because that was very clear for the first time demonstration that the same environmental exposure will have fundamentally different effect in individuals with different genetic predispositions. And then looking at it one day, it suddenly dawned onto us that a graph like this can explain all of the discrepancies in the worldwide literature on asthma and CD14. Because imagine, you decide to do your genetic association study in Tucson, Arizona, where exposure to endotoxin is very, very low. It's desert. What you will find here is that C allele is risk and T allele is protective. Exactly what Fernando has found. If you go and do your study in a population with high level of exposure, farmers, Hutterites, you will find exactly the opposite. Now, C allele is going to be protective and T allele is going to be risk. If you do a study in a population exposed to medium levels of exposure, like most big German and UK cities, you will find no association whatsoever. So indeed, same genotype can increase your risk, can decrease your risk, or will not matter. And that will depend on what the environmental exposure is. We then went on, and I think the next story, I like it even more. It's a story of dirty, pretty things. This idea that a little bit of dirt is good for every child. A body of literature has come up from various parts of the world, demonstrating very clearly that the strongest protection against asthma and allergic diseases is farm living. Children who live on farm don't get asthma. What about children who are exposed to microbes in cities? And where do you get exposed? Well, if you go to daycare, to nursery, it's like a zoo. You get exposed to every type of bug you can think about. So amongst other studies, we have demonstrated very clearly that going to nursery in first 18 months of life was strongly protective against subsequent development of asthma. Actually, children who went to nursery in the first 18 months of life had half the risk of having asthma when they were in a school age. And university did a bloody good job with PR. New York Times picked it up and published the article. We finally have the answer to asthma. We should just send all of the children into daycare and asthma is going to disappear. At the time, Fernando Martinez has joined us as visiting professor, and these are his data from Tucson, Arizona. And we looked at these data, talked about it, and said, well, okay. So we have farming as a proxy of microbial exposure. We have going to nursery as a proxy of microbial exposure. So surely, similar factors that are operating on farms will be working in daycare environment. And we stumbled upon this paper that nobody ever actually quoted, which I thought was quite remarkable. It's work by Erika von Mutius, showing that, yes, indeed, as a group, children who live on farm have considerably less asthma and allergies, 3 times less. But she then stratified them according to genetic variants in toll-like receptor 2 gene. TLR2 makes sense because it may be one of the way we handle microbes. And a small group of children here who were A allele homozygotes, who were living on farms, actually had very high prevalence of asthma. So we decided we would try and test this, but now in a daycare. Looking at 80% of children who are wild-type homozygotes and heterozygotes, it was fantastic to go to daycare. Okay, the risk of asthma was reduced by 70%. Absolutely fantastic. However, what this very successfully managed to hide was that in the remaining 20%, children who were A allele homozygotes, not only that going to daycare did not prevent development of asthma, it actually doubled their risk. Same environmental exposure that was good for some harmed others. Surprised? That's life, isn't it? As pediatricians, we always have to think about the major paradigm, primum non nocere. No intervention should harm anybody. Of course, when you look at the level of population, their care looks good. And that's purely the function of the fact that children who benefit outnumber those who are harmed by a factor of 4 to 1. Now, if you are amongst 20% unlucky ones, that will not be a lot of comfort for you. So the simple story of genes and environment is that, yes, indeed, in a study, same genotype can be good, bad, or will not matter, which will critically depend on your environmental exposure. But interestingly, same environmental exposure, and let me put to you, asthma drug may be highly protective in some, but increase the risk in others. And this will depend on genetic predisposition. And until we know how to identify those who will benefit and those who will harm, it is very, very, very difficult for me to accept that we should go and do intervention studies at the level of population. Now, the other thing is that we very often take things at their face value. But you know, Fedra said things are not always quite what they seem. So we address this issue that is often forgotten in this interesting, curious story of antibiotics and asthma, the study that has been done by Aida here as part of her PhD. You know, antibiotics increase the risk of asthma. Of course they do. It's hygiene hypothesis. You give antibiotics, you mess up the gut microbiome, and as a consequence, you have development of asthma, right? We ask the question in a slightly different way. Why do children get prescribed antibiotics? Well, kids get prescribed antibiotics because they get ill. And when they're sufficiently ill and they have severe symptoms, they go to doctors. Actually, seeing a doctor is a critically important thing for getting an antibiotic prescribed. So is it actually upside down? Is it that children with increased susceptibility to infection, with higher number of infections, more severe infections, go to see their doctors, and their doctors then go and prescribe them antibiotics? Is this why we see this interesting association? And again, together with Seb has done mapping of antivirus immunity in children in our cohort at pretty much industrial scale, demonstrating very clearly that children who receive antibiotics in early life have impaired antivirus immunity when they're in their school age. We cannot guarantee, but the most likely explanation here is they have impaired antivirus immunity, more frequent, more severe infection, see their doctors, doctors prescribed antibiotics. So we ask the question, well, okay, if that's the case, can we find genetic associate, genetic risk for having antibiotic? And yes, indeed, we can. Is the same genetic variants that predispose kids for having asthma that actually can be used as a marker of antibiotic prescription. This is the case of gene-environment correlation. The factor that we think is environment, antibiotic prescription, is just a marker of somebody's genetic predisposition. So it is tricky. What matters? Well, all sorts of things happen. Genes matter, environment matters, timing of exposure matters. Epigenetics, if you don't understand anything, you say it's epigenetics. I will not even touch it. And it's phenotype definition. We go back to what Nicola Wilson has been talking about. Virus hyperresponsiveness, atopic hyperresponsiveness, bronchial hyperresponsiveness, different subtypes of asthma. And phenotype is a buzzword in asthma now. So what is phenotype? It is. It's what you see, isn't it? It comes from Greek word, it is what you see. It's observable characteristic of an organism, obviously, driven by genetics. So it's what you see. And there comes my problem with phenotypes, because what you see, ladies and gentlemen, is what you want to see, not what is there. And I tell this story. I look into the mirror in the morning, and I see the young guy with long blonde hair. It's totally delusional. Aina says, silvery. But that's what I see. Think how many times have you seen what you wanted to see rather than what is there. So what do we do? How do we phenotype asthma in clinical practice? Well, we ask about wheeze, airway inflammation, response to medication, assess exacerbation, measure allergy, lung function. These are phenotypes. We can see them. We can observe them. And then, conveniently, we say this is all asthma. It's nice. Nice, good umbrella term. It's asthma. And anybody who has thought about asthma for a minute knows that under this umbrella, there are very, very different patients. There are children who start wheezing early and stop. There are those who wheeze persistently. There are those whose asthma starts late. Those who respond to treatment beautifully and you never see them again. And then those who end up in Andy's and Sejal's clinic who don't respond to asthma treatment. Now, the key question here, all of these, are these actually different diseases, different endotypes? Because if they are different diseases with different causes, then treating them all the same with inhaled corticosteroids is absolute nonsense. So that we are all on the same page, sort of going from now on. When I talk about asthma, I'm reverting back to Nicola Wilson's 1988 definition. Asthma is not a disease. It's just an umbrella diagnosis for a number of different diseases with distinct mechanisms, with different genetic and environmental associates. Phenotype is what you see, observable characteristics. Now, what you see, observable characteristic, same observable characteristic can be consequence of completely different mechanisms. Think fever. You see a child with a fever, 38.7. My God, how many different causes of that fever. We wouldn't dream about calling fever a disease. And yet we're calling asthma a disease. Just a nonsense. Endotype is a subtype of disease, of a complex disease, where you clearly define mechanisms. Now, the problem is this is something that we want to have in asthma, but in all reality, we don't. It's still purely hypothetical construct. We all say there are asthma endotypes. When you ask a question, well, what they are, well, everybody will give you their own personal opinion. Opinion doesn't matter in this case. Endotype is when you have a clear pathophysiological mechanism. But I think concept is very, very important, because if you are to deliver personalized medicine, if you are to stratify treatment, if every patient is to be given drug that will help that particular patient, you need to understand what is the pathophysiology of the disease they have and what will be the treatment that would be appropriate for that individual person. So, how do we get around finding these asthma subtypes? Well, we know a lot about asthma. We've learned a lot. It starts in early life. Symptoms may progress, remit, or relapse over time. And perhaps this pattern of symptoms, this temporal analysis of when symptoms stop, start, go away, restart again, may be fundamentally important to understand these different diseases. If this is true, then population-based birth cohort is the only way to understand it. And my God, was it clever to start a birth cohort, actually, wasn't it? So, have birth cohorts taught us anything? Well, this is one of the most famous papers in respiratory medicine, full stop. Probably one of the highest quoted papers. People said, Fernando is a great friend and collaborator, and long may it continue. In Tucson Children's Study, described these three different phenotypes: transient wheezers, late onset wheezers, and persistent wheezers. What Fernando did was he tested the hypothesis that Nicola Wilson proposed 7 years earlier. The clinical observation tested in birth cohort has really demonstrated that there are different wheezing phenotypes. But this really was imposing the solution on the data that was there based on somebody's observation. In the UK, we took very, very different view. We thought, actually, what we need to do is to pull together, is to get all of the birth cohorts. Angela Simpson has gone around the country and found 5 of them: Manchester, Aberdeen, Ashford, Isle of Wight, and Elspeth. Let's put them all together and let's start thinking about this problem. And here are the people, John Henderson and all others. And collaboration with these guys has been absolutely fantastic, the highlight of my career. What we wanted to do was kind of simple: bring together 5 birth cohorts. And very, very, very soon we realized that actually what we have is tremendous amount of data. And that the underlying patterns within the data were anything but obvious. We couldn't see them. They were not observable. And it became clear that standard epidemiology has run out its course, that we have to embrace the new developments in mathematics, in computer sciences, and statistics to understand this problem space. And the first test case, really without this, I don't think Stella would ever happen. And John is here. John Henderson applied latent class analysis to a question, large questionnaire, similar to what Fernando has done, but now not imposing solution, but asking a question: what is the structure within the data? And the answer was the structure within the data was much more complex than that described in the initial paper by Fernando. But this is what the data has said. This is data-driven. Interestingly enough, though, in these big studies, we apply really big questionnaires. 107 questions, right? 107 questions. We then conveniently throw 106 questions into the bin and use question, has your child wheezed in the last 12 months? And we base all of our knowledge and all epidemiology on this single question. Didn't make sense at all. So we thought there must be a way of utilizing all of this data. And at the time, Jackie Smith, now Professor Smith, was a research fellow with us. And her boyfriend was a psychiatrist. And we were discussing this problem, and he said, well, in psychiatry, we use this interesting mathematic technique called principles component analysis to understand the patterns of responses in psychiatric diseases. We thought, wow, that's the answer. Let's take all of the questions from all of the questionnaires and see what that is going to tell us about respiratory disease. And what it told us about respiratory disease was fascinating. There were 5 different diseases there, each characterized by responses to a unique set of questions. Out of 107 questions, 27 were informative. 27 were important. The question, has your child wheezed in the last 12 months? And has your child wheezed without colds? The cornerstones of asthma epidemiology were not amongst them. Doesn't mean they're not important. They are important. They just don't help you differentiate between subtypes of asthma. So it was interesting. Then we asked the next question. Okay, so we are relying on parental report. We are believing what parents are telling us. So how accurate is parental report of wheezing? As a part of IFWIN, of the study that I've shown you before, we have asked some 300 pregnant ladies when they deliver and when their child starts wheezing to give us a ring, and we guaranteed to be in a house within 45 minutes. And Nick Nicolaou did that. And it's interesting, amongst 300, almost 300 babies, 122 parents said that their child was wheezing. We got the doctor in their home within half an hour, but the doctor could confirm wheezing only in 2/3 of cases. 1/3 of parentally reported wheezing was never wheezing in the first place. And then we're looking at risk factors of something that never was. Quite interesting. Is it real? Well, it is, because we then follow them for the next 3 years, and 3 years later, children whose parents reported wheezing and in whom we confirmed wheezing had markedly poor lung function than those whose parents reported wheezing, but we couldn't confirm it. They were no different to healthy kids. So we thought, okay, relying only on parental report is not enough. We have to do something else. So we sent Ada to spend 2 years of her life in primary care transcribing healthcare records from 1,000 children. They tell you you can pick it up electronically. Not as yet, not as yet. So now, having a hell lot of information from parental report, from healthcare records, confirmed and unconfirmed wheeze, Danielle Belgrave went on to design really interesting, complex latent class analysis. Now, taking into account all of that information. And what it revealed is, for me, was fascinating. Because the phenotype that Fernando talked about as persistent wheezing was split into 2 groups. Large group, which we called persistent controlled wheezing, and a small group, about 10% of patients with asthma, which we call persistent troublesome wheeze. Why troublesome? Well, they're all on inhaled steroids. They all have other asthma treatments. And yet, despite these treatments, asthma exacerbations, hospital admissions, and unscheduled care are happening in this small group of individuals. Familiar? Severe asthmatics, 10% of them who consume 80% of resources. Not only that, these kids progressively lost lung function during their childhood. Now, what is doctor-diagnosed asthma? Well, doctor-diagnosed asthma is a mishmash of these different diseases. Some of them transient, some of them late onset, some of them troublesome, some of them controlled. Now, how are the genetic studies of asthma done? What is the phenotype? It's doctor-diagnosed asthma. It's apples and pears with few pineapples and lamb chop. And you aren't getting anything. Surprised? So we thought there must be a better way. Will better phenotype definition give us hints, give us clues as to what is going on here? So with Hans Bisgaard from Denmark, we decided to look at curious phenotype, severe early onset asthma with frequent exacerbation. And the genome-wide association study revealed a completely new genetic association called CDHR3. We then went on and looked at the association of this genetic variant with severe asthma exacerbation and hospital admissions, and it was quite extraordinary. There was a clear risk group. And this mutation here was a coding mutation, which means that it actually has a consequence on the protein that was being produced. There was an amino acid change. It's functional. And the children, small group of children who are unlucky enough to have this genotype, end up in hospital very, very, very often. Now in ALSPAC, this is work that John has done very recently with Raquel Granell. This genetic variant is not associated with doctor-diagnosed asthma. And amongst the group of persistent wheezers, it's only associated with persistent wheezing with hospital admission. We then went back to our latent classes to demonstrate that this is uniquely associated with persistent troublesome wheeze. And amongst asthmatics, children who carry the risk genetic variant are 3 times more likely to have troublesome disease. Now, these are now serious increases in risk. At the same time, one of our colleagues in the US was looking for a receptor for rhinovirus C and has postulated that this genetic this CDHR3 is actually a receptor for rhinovirus C. Mike Edwards and I think there's much more to it, and we hope to probe this in months to come. But this is certainly a developing story. We then ask the question, well, okay, if your asthma is just a mishmash of different diseases, what about allergy and allergic sensitization? You know, we all know what allergic sensitization is. You have positive skin test and positive IG. Well, what on earth are these cutoff points? They are meaningless. This cutoff point of 0.35 kilounits per liter used to be a lower detection limit of the assay in 1986. We call children allergic or not based on lower detection limit. Insane. And Andy and Sejal and Louise published this, which was really, really, really beautiful piece of work looking at the patterns of allergic sensitization in their group of difficult asthmatics and severe therapy-resistant asthmatics. And although all children were sensitized, pretty much all of them, what characterized severe therapy-resistant asthma was that the skin test responses were really large. And this went very well with our data showing that what characterizes persistent troublesome wheezing is very high level of IG. So we asked the question, well, okay, does the pattern of IG responses, the type of allergens you're allergic to, the timing of onset of that sensitization, can that tell you something about this phenotype of allergic sensitization? There's blood test, there's skin test, there are 8 different allergens, there are plenty of different time points. How do you see the patterns here? You can't, clearly can't. And this was the first time we turned to machine learning. Our friends and colleagues in Microsoft Research Cambridge were developing these large platforms, Info.net, which was framework for running Bayesian inference, underpinned by methodologies that allow them to personalize your advertisement based on your browsing. You know that. 3 minutes browsing, you get your personal ad. How do they do that? They look at patterns. So we thought, I mean, come on, if they can personalize advertisement, surely we can personalize treatment. So the guys there completely reformed their platform. We came up with a novel methodology. A guy called Vincent Tan from MIT developed it. And we built that model, which wasn't just looking at the data. It was actually informed by everything that we knew up until that date about allergic sensitization. And what that has shown is that there is no such thing as sensitization. What we call allergic sensitization are 4 fundamentally different subtypes, only one of them comprising 25% of allergic children being associated with asthma. But now the risk of asthma goes 30-fold. Now that is pretty spectacular. Our colleagues from Isle of Wight then repeated this. Different allergens, different time points. Same structure within the data. It is real. And only one subtype of atopy is important in asthma. Why is it important? We can finally identify a risk group. We know that children who are at risk of progressive loss in lung function during childhood are those with multiple early sensitization and persistent wheezing. Now, to all of us in Stella, it became clear that integrating data was not enough. Having the data together would not do the trick. We needed more. We needed to integrate data with methodologies that were unfamiliar to us and with investigators together. So we brought together our birth cohorts with health informatic research in Herc and Fire Institute and statistical machine learning in Microsoft Research Cambridge and have created an online platform to support it, which we call eLab. All of the data from all 5 birth cohorts are in a repository there. You can get the data out, but more importantly, you can actually do all the analysis and communicate between like-minded scientists online in real time. You know, you can search for variables. You can use Google-like terms. You can shop variables, put them in a basket like Amazon, and all of that gets recorded and audited so everybody knows what has been done at which time point. So we thought we will tackle now the big issues, the big dogmas, of atopic march, because obviously the way allergy develops is you get eczema, and after eczema you have asthma, and after asthma you have rhinitis. And certainly at population level, that's what happens. So these are the data from 10,000 kids in our 2 birth cohorts in Elsbach in Manchester. Beautiful, beautiful allergic march. But does the fact that at population level these change, is it actually a reflection of what is happening at individual level? Does it mean that there is this progression in the same children? So Danielle Belgrave, again with guys from Microsoft Research, did these 3 models to try to capture the individual progression, which has shown very clearly that atopic march is a myth. Only 6% of children with any of these symptoms follow this trajectory. 75% of kids with eczema never develop anything else. And what this has also shown is that by pulling this together, we can learn more about the disease than by focusing only on one symptom, like wheeze. There is a link between these diseases. It's latent. It's there. We need to understand it. But it doesn't follow the progression. The idea that you can stop children developing asthma by targeting those with eczema is fundamentally flawed. I know that companies have spent at least $100 million pursuing this particular idea. So where are we today? Are we any better than we were 25 years ago when we started? Well, you know, there has been a shift from Nicola's proposal in 1988. Now everybody accepts that asthma is heterogeneous. There is a consensus that there are different asthma phenotypes, and there are different asthma endotypes. There is no consensus at what these are or how to define them. We are facing a major challenge here of how to identify subtypes of asthma at population level, how to identify them at case level amongst patients in ND's clinic, how to link these two, how to understand their causal mechanisms, and how to translate this knowledge into genuine improvement in healthcare. Can big data provide solution? We thought that big data would be the answer to it all. And indeed, the vast increase in the amount of data that we can produce now, at moments you kind of think, what on earth? You know, I don't know what to do with this. I don't know what are the questions to be asked. And the data-driven, you know, hypothesis-free methodologies are very quickly overshadowing the traditional hypothesis testing or hypothesis-based research. My concern is that big data is now being sold to us as a new panacea. It's a new dogma. The data will and must speak for itself. Well, the data will never speak for itself. Data is not knowledge. I wish I had said that. Data is not knowledge. The mother of all knowledge is experience. It was Albert Einstein. I mean, what a wonderful, wonderful thought there. More data doesn't mean you're going to do better research. There are real dangers because we have readily accessible tons of data. Data mining is now becoming completely uncoupled from process, scientific process, and clinical interpretation. We need to link these two. Big data are key, but we need to link big data with big reasoning. Advances in computer sciences are fantastic and we should utilize them, but we should use it in a meaningful way to put big reasoning together with big data. The solution to the problem is team science. There is no other solution. I always thought that scaling up means getting more birth cohorts on board. In the last few years, we came to a solution that birth cohorts, irrespective of how wonderful they are, cannot provide answer to everything. Patient cohorts are equally interesting, giving us different window of looking at the disease, different window of human development. You need variety of population environments. It has to be multidisciplinary. It has to be multi-perspective. Is it machine learning or statistics? Who cares? It's whatever the best method is to address the question that you're asking. Blending it all together in the tapestry of reasoning about mechanisms is the way forward. It has to be hypothesis forming, but also following. This is how I see it. These different studies see different facets of a problem. Birth cohorts see it from one aspect, patient cohorts from another. Randomized controlled trials, wet labs see it from a different angle. They all see the true findings. None of them alone can see the truth. And what this is about is finding the truth. So we have to find a way to pull it all together. Unfortunately, there's a huge methodological issue here, that we don't have a clue as yet as to how to translate the findings from our birth cohort into our clinic population, because they are very, very, very different. And that's a bit of work that needs to be done. So my answer to the problem is, actually, what we need to do to answer this problem and find cure for asthma is put all the pieces of evidence together. Birth cohort, what I call Stellar Plus, extend with important cohorts that can be informative. Our friends and colleagues in US have just got an NIH grant to put 12 US birth cohorts using exactly the same platform and methodology that we're using in the UK. It's unprecedented opportunity to get important answers, but we need to link it to the findings from clinical cohorts. Andy's early childhood wheezing, UBioPred, all of these tremendously informative studies which all currently live in their own separate universes. We need to tackle the issue of linkage with the records, data protection, and governance. The solution is integration. Clinicians need to start talking to statisticians, to computer scientists, to physicists, to geneticists, basic scientists, and epidemiologists. All of these people working together to understand the heterogeneity of asthma. It is team science rather than selfish science. The problem is, everything that we do currently is based on the principle of selfish science. Who is a principal investigator? Who is a leading institution? Who is a first author? Who is a last author? That nonsense needs to stop. My vision is that of team science. And with that, how about that team? All the friends and colleagues from Manchester, Angela Simpson, Ian Buchan, John Henderson, Graham Devereux, Steve Turner, Paul Cullinan, Graham Roberts, Hassan Arshad, John Holloway, Chris Bishop, John Wynn, Fernando, Seb Johnston, Pat Holt, and all other friends and colleagues from around the world. All of the wonderful people that I've worked with over the last 25 years, over the years, hey, they have all changed. The only one has stayed the same is me. There's Gina Carey, who has been absolutely instrumental. This young lady here is Claudia Gore. All the doctors, nurses, basic scientists. Key person nowadays, Danielle Belgrave, statistician and modeler, who is now here with me. And with that, where I want to be, well, I think this is kind of my mission statement. I have precious little to add to what Feuerbach has said, and I fully agree with him. And I thank all of you for coming and for your attention.
I'm Ashley Woodcock from Manchester, and I have to take some responsibility for this phenomenon. Adnan's very generous with his credit, but 25 years ago he came into my office, he knocked on the door and said, more or less, give me a job. And just occasionally, once in your life, some phenomenon happens that you realize you've got something remarkable coming to meet you. And we've been great friends ever since, the best of friends. And so I find this quite an emotional moment in many ways, because Manchester's loss and my personal loss, that Adnan's not seeing me every day and drinking all my coffee, is Imperial's gain. And I think that him moving here will be to the greater good of the science community, because as you can see, he is phenomenal at pulling together people to work synergistically and in a collaborative way. And I do hope that, I'm certain that Manchester is going to be part of that greater collaboration. I want to say thank you to the cameraman who's dizzy. First time, I guess. And I was worried about him. And I want to thank you all for coming, but I think that you will all agree with me. It's been phenomenally worthwhile being here today to see this tour de force. Thank you very much, and thank you to Adnan.